Understanding the role of laparoscopy in pancreatic cancer diagnosis. Hello, this evidence-based content is prepared by Saboor fellowship-trained consultant surgeon, and if you or someone you care about has been diagnosed with pancreatic cancer, and you're wondering whether that CT scan has told you everything you need to know, you're in the right place. I know when you hear more tests or another procedure after already facing a cancer diagnosis, it feels overwhelming. But today we're going to talk about staging laparoscopy, a procedure that might actually save you from an unnecessary major operation. Staging laparoscopy, sometimes called diagnostic laparoscopy, is a minimally invasive surgical procedure where surgeons insert a tiny camera through small incisions in your abdomen to directly look at your abdominal organs. Think of it as giving your surgeon a direct visual inspection of your peritoneum, that's the lining of your abdominal cavity, to find cancer spread that imaging studies like CT scans simply cannot detect. This matters to you personally because it can prevent you from undergoing a major operation that wouldn't help you live longer. Available imaging techniques are highly accurate at predicting unresectable disease, but they fall short in predicting resectable disease, mainly because of limited sensitivity for small-volume metastatic disease. When it comes to detecting peritoneal spread, that's cancer deposits on the abdominal lining, the sensitivity of CT for peritoneal dissemination is not sufficiently high to eliminate the need for diagnostic laparoscopy in equivocal cases. The data reveals that CT scans can detect liver metastases with sensitivity ranging from 53 to 89%, depending on the size of the lesions. But here's where it gets interesting. Peritoneal involvement may only be detected indirectly by CT through the presence of ascites, mesenteric nodules, or enlarged lymph nodes. If you're supporting someone through this diagnostic journey, understand that a clear CT scan doesn't always mean clear disease. Most surgeons use a selective approach to staging laparoscopy, limiting the procedure to those with the highest likelihood of occult metastatic disease. This selective approach maximizes yield by performing it only when there's genuine concern about hidden disease. Diagnostic laparoscopy should be performed before the start of neoadjuvant therapy, that's chemotherapy, given before surgery. We consider performing diagnostic laparoscopy in patients who have potentially resectable disease, but one of the following features. Imaging is suggestive but not diagnostic of metastatic disease. That means the radiologist sees something concerning on the CT scan, but can't definitively call it cancer spread. A tumor of the body or tail of the pancreas. These tumors are diagnosed at a later stage, when peritoneal spread is more likely than pancreatic head tumors. If this applies to you or your loved one, this is when staging laparoscopy becomes crucial in preventing futile surgery. In one analysis, surgical resection was avoided in 20% of patients using additional imaging information, and staging laparoscopy can identify even more patients who wouldn't benefit from major resection. Because ductal adenocarcinomas involving the body or tail usually don't cause obstruction early, a significant proportion will have occult peritoneal metastases even when CT looks reasonable. The procedure is typically coupled with portacath placement if chemotherapy is planned. Surgeons make small incisions, usually just a few, and insert a laparoscope, which is a thin tube with a camera and light. During the procedure, surgeons systematically examine the liver surface, the peritoneal lining, the omentum, that's a fatty apron hanging from your stomach, and areas around the pancreas. Some surgeons routinely perform peritoneal washing at the time of diagnostic laparoscopy, collecting fluid from the abdominal cavity to examine under a microscope for cancer cells. The presence of cancer cells in peritoneal washings is associated with a worse prognosis in patients with otherwise resectable disease, and the American Joint Committee on Cancer Staging System considers positive peritoneal washings to represent distant metastatic disease. However, if extensive ascites or obvious metastases are absent, most pancreatic surgeons would not rely solely upon peritoneal washing results. The procedure itself is minimally invasive, typically performed under general anesthesia, and patients usually recover much faster than they would from major abdominal surgery. We're talking about potential discharge the same day, or within 23 hours in many cases, versus weeks of recovery from a major pancreatic operation. The fundamental goal of staging laparoscopy is identifying patients who would not benefit from major resection because they have unresectable metastatic disease that wasn't visible on CT imaging. Pancreatic surgery, whether it's a pancreaticoduodenectomy, Whipple procedure for head tumors, or distal pancreatectomy for body and tail tumors, carries significant risks. We're talking about operations with complication rates around 30 to 35% and hospital stays averaging 7 days or more. If staging laparoscopy finds peritoneal metastases, it spares you from that major operation that wouldn't extend your life. Instead, you can proceed directly to appropriate chemotherapy without the setback of surgical recovery. You maintain your strength and quality of life to receive the treatments that will actually help you. For patients where laparoscopic exploration reveals no evidence of metastatic disease, the surgeon can then confidently proceed with the planned major resection, knowing it has the potential to be curative. Ask about staging laparoscopy if you have potentially resectable pancreatic cancer. Given my tumor location and CT findings, Would staging laparoscopy help clarify my treatment plan? This is particularly important if your tumor is in the body or tail of the pancreas, or if your imaging shows any concerning but unclear findings. What percentage of your patients with similar presentations end up having occult disease found at staging laparoscopy? Gather your imaging reports and understand your disease extent. Request copies of all your CT reports and pathology results. When the report says equivocal findings or cannot exclude peritoneal involvement, those are phrases that should prompt discussion about staging laparoscopy. Research your treatment center's approach. High-volume pancreatic cancer centers have more experience with selective staging laparoscopy. If you're not already at such a center, consider getting a second opinion from one. The data shows improved surgical results for pancreatic cancer at experienced centers. If you're supporting someone through this, help them prepare questions. Write down concerns about whether the CT scan has shown everything. Bring a notebook to appointments to capture the surgeon's explanations about why staging laparoscopy is or isn't recommended in their specific case. If you have pancreatic cancer of the body or tail that appears potentially resectable on cord, research demonstrates a significant proportion will have occult peritoneal metastases requiring staging laparoscopy before attempted resection. If your imaging is suggestive but not diagnostic of metastatic disease, this equivocal finding is precisely when direct visualization adds the most value. Before starting neoadjuvant chemotherapy for borderline resectable disease, staging laparoscopy performed before the start of neoadjuvant therapy helps ensure you're proceeding down the right treatment path from the beginning. If your tumor shows concerning features on imaging but you're being told surgery is still an option, getting clarity before major surgery ensures you're making informed decisions with all available information. The timeline matters here. Staging laparoscopy should be performed before neoadjuvant therapy begins. It can be at the same time as portocath placement if chemotherapy is planned. Don't wait until after multiple rounds of treatment to have this assessment done. Staging laparoscopy is a minimally invasive procedure that finds hidden peritoneal disease missed by CT scans, preventing unnecessary major operations in patients who wouldn't benefit. Your next step: discuss with your oncology team whether staging laparoscopy is appropriate for your specific situation, particularly if you have body or tail pancreatic tumors or equivocal imaging findings. This information is for education. Always discuss your individual situation with your healthcare provider. I've outlined several reputable resources here, which you may find valuable for further information on this topic. All links are available in the description below. Thank you for watching.